Andrew Russell.
Yeah.
Because we can refer them.
That's what I told him. I'll buy food. I was like, do you want, he goes, I need money. And I was like, I'll buy you food. And I was like, and they say no, a lot of them. Yeah. And he goes, no, can you just give me the money? And they're like, no. When I went to the canasta once and there was guys outside asking for money, I was like, no, but go and order some tacos and tell them that I'll pay for it. And they went and ordered the tacos or drinks, whatever they wanted to eat, and I paid for it. Like, yeah, that's fine. Like, order whatever the heck you want to eat, but just, I'm not giving you money. That's why I thought of you.
Oh, really?
Yeah, and I see these girls are beautiful. They look very comfy.
I wanted to get one.
One of the times that my dad went to Vegas and stuff, this guy's just like, I need some beer, and he gave him a $5 bill. He's like, at least you're honest, okay? Right.
Lives in New York, or he did live in New York. I don't know. He said that they would see people in Times Square and like always and he said people would give him money.
I mean, as long as you're being honest, I guess. You know what my husband did in Mexico? Stole from us. And my husband gave him like basically all the money that we had. Oh my god. Pesos, and they were so happy. And then I told my mom about it because she lives in Mexico, right? And she goes, "Are you serious?" She said that we would go to their houses and beg them to work, and then the kids would. They're like, no, because the kids bring in things. My mom went to, she just came back from Mexico, and I don't know if it's family members or someone she knows, and I brought her like animal cookies, just like a little jar of animal crackers, and she's like, the little girl loved it, she's like, she wanted them. I'm like, then what did you do to them, Mom? Like, they're not cute. She's like, no, because her mom made me mad. I'm like, Mom, it's not the mom's fault. We'll buy you some more freaking animal crackers. Yeah, like food like that, right? Yeah, I know, but the little girl's mom made my mom mad. She's like, she's dumb. It's not the little girl's fault, Mom.
Your mom is so bad.
I know. But the mom, I guess, got mad at the daughter. The little girl's like,
That's the recommendation.
and she wouldn't like leave her conversation. Mom, I guess, grabbed her hair and just cut it. Mom got mad because she did that. Like, no. I would like keep them. I would let her keep them. She's shy. Heidi, ordené los zapatos. I think you're coming from one. You want the on clubs? Oh. Yeah, I told Letty that I'm in like a manic episode, so they're really pretty.
Never.
Aren't they? I know. I really hope they sent me, but they have like a 90-day. Online, so on cloud. My husband, surprised me with it. I told him I'm in a manic episode.
Your car's. What is that?
A Genesis.
Do you know what that is? I don't even know what that card is.
I didn't choose it, my husband.
Oh, it's this song. This is the purse.
He surprised me with it.
The purse right here, and I was coming, and she went like that. Even says her name.
I'm like, oh, waited till I passed.
That's your mom? No, I didn't honk. I was like, okay, I'm just gonna let it go. And then this girl was still trying to go in, so that's why I went in there and she honked at me. Oh. I'm so mad.
I told him that's right. For what?
I didn't think it was gonna be this cold today.
I know, it's cold. There's a cold front pushed through, and then it's gonna warm up just a little bit, and then another cold front, and then next week over Thanksgiving, another cold front.
That makes sense. My body's been hurting the last couple of days. I feel old. Just like it's in my hips and my knees and my back.
Okay, we're gonna go ahead and get started. We're gonna talk about some babies today, okay?
I know more.
So this is chapter 26 and 27 in your book. We're gonna identify some pregnancies that are gonna cause some high-risk babies and how we're going to prepare for the delivery and what will happen after delivery. So again, with labor, delivery, pregnancy, you know, every time I have a patient come in, I tell her, our goal is happy mom, happy baby, healthy mom, healthy baby. Don't care how they get there. Don't care vaginal versus C-section. Our goal is to make sure everyone comes, everyone's healthy, okay? So, your student learning outcomes are the next 3 slides, okay? So this will be your last test, it's just the content from this lecture, okay, prior to the final. And there's a lot of good content to test over, okay? But again, we will do the a case study. I'll have it uploaded by the end of this week, and you'll have a little bit more time because next week's Thanksgiving. I don't expect for you to work over at Thanksgiving break on it, but if you want to, you can. I'm gonna have it there available for you to do it if you want to. You don't have to. You'll have that next week. You're welcome. Okay, so pregnancy risk factors for a high-risk newborn. So these are some things that are gonna cause potentially some things to be wrong with baby, okay? Low socioeconomic levels for parents, mom. Poor diet, she has a low income, so therefore she can't have a good diet. Limited access to healthcare, prenatal care. Fortunately, the last one is not necessarily something people can claim. If you are low income in most states, you can get emergency Medicaid for pregnancy. You know, so a lot of people are like, oh, I can't afford healthcare. Medicaid almost will cover almost anybody, even almost the middle class. The rate's pretty high. Your income level is pretty high when you're coming to pregnancy. So you can't claim, I don't have any money to pay for insurance. Okay, Medicaid's pretty readily available to most people. Okay, only reason would be if you know you are outside of that range and you choose not to have insurance and you probably could afford it. Okay, exposure to environmental factors. So if you live in high altitude, you work somewhere that maybe you're exposed to toxic chemicals or you use illicit drugs. Pre-existing conditions such as diabetes, cardiac disease, hypertension, thyroid disorders, renal disease, anemia. Other maternal factors can be age and multiparity. So a lot of people think, oh, age, we have a lot of people getting older for having babies. Well, you have to think about the eggs that women carry are in their body from the womb. They're formed in the womb. You don't add eggs after you're born. So instead of having a baby at 23, 24, at 53, 54, do you think the age of that egg could affect how that baby develops and the growth and healthiness of it? Yes, it can. Okay. It's an older egg, therefore you have a higher risk of problems. And we do have lots of women now having babies in their late 40s, early 50s by choice. I watched a TikTok video last night of a man who was 27, his wife was 53, and they've had 2 babies. Other pregnancy complications, gestational hypertension, preeclampsia, multiple gestations, so twins, triplets, or more, preterm labor, abruption, or previa, oligohydramnios, uterine rupture, UTIs, rubella, herpes, CMV, which is that cytomegalovirus, syphilis, maternal pregnancy history. So she's had a history of stillbirth, miscarriage, C-section, or RH sensitization. Okay. So neonatal mortality versus morbidity, okay? So there's a chance of death within the first 28 days of life. 75% of all neonatal deaths occur in that first week. The highest chance is in the first 24 hours, okay? Risk to the neonate decreases as gestational age and birth weight increases. So the closer you get to term, the lower risk you have of baby potentially passing away after delivery, okay? So the longer they cook, the better they are, okay? Morbidity risk for the neonate, you have hypoglycemia, neonatal distress, congenital anomalies, or polycythemia. So respiratory distress, that's kind of our first thing we think of, really with any baby, because really potentially any baby has the risk of coming out and having some form of respiratory distress, okay? So respiratory distress is an increased respiratory rate, retractions, nasal flaring, grunting, and excessive mucus. So tell me about retractions. Where could we potentially see retractions? Okay, rib area. You can see below the ribs, above and around the clavicles. Okay, there's several places you'll see retractions. It doesn't have to just be in the ribs. It can be here. It can be below. Okay. Nasal flaring, so that's that nostril moving in, open and kind of closed, bigger and smaller. Grunting is kind of the you'll hear that noise. Okay, that's grunting. And just excessive mucus, okay? I will suggest that if it's highlighted or underlined, it's probably important to know. Okay. Gastrointestinal, abdominal distension. Okay, these babies, when they're born, if they're born really, really fast or they come via C-section, they're not getting a good squeeze of that abdomen and chest. And so therefore, they're going to have excess amniotic fluid inside that tummy, or even air once they're born, and all the excessive crying they do, which we want them to do, can pull in extra air so they can have abdominal distension. Projectile vomiting, bile-stained emesis, absence of meconium, and they have up to 24 hours to poop, okay? We don't expect them to poop within that first 24 hours always, but if they get past 24 hours and they haven't pooped, we need to assess what's going on. Do we have a patent anus? Do we have a bowel obstruction? Is something there that's causing baby not to poop? Gastroschisis, we'll talk about that in a little bit. So what are some other signs? Cardiac, so they could have central cyanosis. Tell me what's normal as far as cyanosis goes in a newborn. Hands and feet, and how long does that normally last? About 24 hours. Should be about 24 hours. You might see a little past, but typically 24 hours. That's what the textbook says, okay? So if it's centrally located, though, the cyanosis, that's a bad sign. That means there's probably some cardiac issues going on. Urinary, if we don't have a baby that voids after 24 hours, again, if they're breastfeeding, we don't expect them to void as much that first 24 hours because mom's not really making a lot of milk. She just has colostrum, which is very small amounts of high concentrated milk. So baby may not pee as often unless they're bottle fed. If they're bottle fed, they're going to pee pretty quick. Jaundice within the first 24 hours is abnormal. We do expect them to kind of get more yellow as the second, third, fourth day comes along. But if it's immediate with delivery or right after, we know that there's something going on. Temperature instability. This is where baby can't keep themselves warm. Okay. If they're not able to maintain their temperature, this is a concern. This is going to be a problem. Jitteriness. Somebody explain to me what's jitteriness. Kind of shaky, yeah, like you'll notice a jitter, okay? That usually is the biggest sign for what? Hypoglycemia. It can be a symptom of withdrawal if we know mom has a positive history of drug use, but your biggest thing is going to be hypoglycemia. Okay. So any blood sugar less than 40 is abnormal on a baby. Symptoms of a sick baby that we're going to see. So these are signs when you see this, then you know that something is abnormal. Okay. So if they're not able to maintain their temperature, they can't keep that normal 98 or above. Okay. It just keeps dropping. You warm them up, you know, then they drop again, you warm them up. If they're having vomiting, and some babies do spit up a little bit, that's kind of can be typical, especially with that excess amount of amniotic fluid in the tummy. But what we're looking for is like excessive vomiting or projectile vomiting. Poor feedings, okay? If they're not going to wake up and eat well, then we know that that can be a sign of something's going on with baby. We do kind of expect baby to not nurse or eat well from about 8 to 24 hours. You kind of have to stimulate them a little bit more because that's when they kind of go into that sleep cycle post-delivery. When the baby's first born, they're very alert, alert and awake and want to nurse and do things. And so that's why we encourage mom to get baby to breast as soon as possible, because we know as time passes further out from delivery, the more sleepy they get, okay? About 8 to 24 hours, 12 to 24 hours, somewhere in there, you're going to notice them being really sleepy, okay? But when you get past that, or in that early stages, they're not even alert, then you know something's going on. Lethargy, where they're not wanting to wake up at all, again, having poor feeding. You have central cyanosis, cyanosis of the lips, apnea. Now, babies, do they breathe regular? No. They breathe irregular, but if you have greater than 20 seconds of apnea, meaning they've stopped, they are not breathing and they haven't caught another breath within a 20-second window, that's considered apneic, okay? So they're irregular, non-labored breathers, okay? So they're not gonna breathe like we do, in and out. It's gonna be kind of fast, then slow down a little bit, and then it'll be kind of fast, and then slow down a little bit, okay? Stools, okay? We expect kind of meconium, right? So we expect the greenish, really thick, tarry stool, right, initially. And then after that, if we see anything besides just kind of that normal transition. So can someone tell me if a mom is breastfeeding, how should that stool transition? What color? Does anybody know? Yellow and seedy. It's going to look like it has little pieces of cottage cheese in it, okay? And it's going to be yellow if it's breast milk babies, okay? If it's formula fed babies, you're going to get more kind of like the normal typical stool, okay? Softer. It's not going to be as formed as it would be on an older child or adult, but it's going to be softer, have more of that poop consistency to it, okay? So I always like to kind of educate my breastfeeding moms, because sometimes they panic, especially if it's for first baby and that stool starts to transition and they're like, oh my gosh, my baby's having diarrhea. Well, it's not diarrhea for a breastfed baby. It's normal for them to have that yellow, seedy, kind of thinner stool, and they're going to poop every time they eat. Happens, okay? And they're going to be a little bit more prone to some diaper rash irritation. So, you know, encourage them to get maybe some butt paste or some Desitin if they start noticing redness, to help protect and form a barrier, okay? It's just the way the body processes it. Yep, the way the body processes it and what it's the components of it compared to formula. Lack of wet diapers. So after that 24-hour period of babies not peeing appropriately, does anybody know how many wet diapers a newborn should have after 24 hours in a 24-hour period?
One for every day. What did they are?
Typically, yes. But most of the time, if they're feeding well, we're going to expect at least 6 wet diapers in a 24-hour period, okay? 6 to 8 is kind of our range, and I tell them from 9 a.m. to 9 a.m., okay? So you're counting. If you have close, you know, if you have 5, I'm not going to be worried about them. But if you have 2 to 3, that's not consistent with what a newborn should be doing if they're nursing well, okay? Mom's milk, does anybody know when mom's milk comes in? 3 to 4 days. Yep. 3 to 4 days is typical. And the more that baby can get to breast and nurse, the faster that body's going to be stimulated to actually start to make milk. If you notice any abnormal drainage from the rectum, from the peri area, from the nipples, from the nose, from the mouth, anything, then that's going to indicate there's something going on, okay, an infection, depending on what it looks like. So small for gestational age or IUGR babies, okay, so these are babies that are smaller than they should be for their age, okay. So AGA babies, which is appropriate for gestational age, so that's what we expect to see a baby at. That means they're between the 10th to 90th percentile. So they took hundreds of babies at 1 day or newborn, measured their weight compared to length, but got an average of what majority of these babies weighed. Okay, so this is how we got our growth scale. So if that baby falls within the 10th to 90th, which is a pretty broad range, then they're considered appropriate for gestational age. But if they fall below that 10th percentile, then they're considered small for gestational age. And of course, this should be more based on your local population, but we have that generalized growth chart that we use that's put out by the Pediatric Association. So for small for gestational age, we also have to remember we got to think about how many weeks they are. So if they're 34 weeks and they weigh 4 pounds, they're probably not small for gestational age. They're appropriate for their age. Okay, so we have to base weight to age also. Okay. Intrauterine growth restriction or IUGR is a baby that undergrows for some reason, and most of the time it's related to that placenta. So is the baby just small, or is it not fulfilling its growth potential due to underlying conditions? So maybe mom was a smoker, therefore placenta wasn't able to grow and have appropriate blood flow to baby. Maybe mom had diabetes, maybe mom had preeclampsia, okay? So factors that contribute to IUGR. So a mom who is a primiparent, what does that mean? First time or grand multiparent, so moms who's had multiple. Multi-gestation or lack of prenatal care. Okay. Maternal disease like heart disease, illicit drug use, sickle cell. How does sickle cell affect and cause IUGR? So we have, what do the cells look like? Sickle. So they're kind of moon shaped, right? Crescent moon shaped. So what happens to those cells? They clump together, right? Occlude off vessels, right? So do we have good blood flow to placenta? No. So therefore, baby doesn't have that appropriate blood flow and nutrition to grow appropriately, okay? Environmental factors that you're gonna see, high altitude, maybe a mom who excessively exercises, could be work related to things that she's exposed to, like toxins, or hyperthermia. This is one of the reasons we tell moms not to take really hot baths or use a hot tub. Okay, at least in a hot bath, the water's going to cool off over time, but if you have a hot tub that reheats the water, you're going to cause hyperthermia. Placental factors, so maybe you have a small placenta. Infarcts, what's an infarct? Tissue damage. Yeah, tissue damage that has occurred and that part of the tissue dies. Just like you have a myocardial infarction, an MI, that's where you have death of the tissue inside the heart. Well, this is infarcts in the placental tissue. Okay, so death of parts of that placenta. Abnormal cord insertion. So we talked about how you can have that like velamentous cord insertion where it goes off, the vessels actually go off the placenta into the cord. Yes. So high altitude, are you going to take in as much oxygen as if you were at sea level? No. Some people, their body adapts to it, but if you're still not, your body's adapted to it, but is baby's body adapted to it? So you're taking in smaller amounts of oxygen than what someone at sea level would, but you're adapted to it, but that growing baby's not. So you're taking in less oxygen, which then can impact baby's growth and development.
Smaller than?
Potentially. Yeah. Yep, because that's why we're talking about IUGR. Yep, they're not going to grow as well because they're not going to have as good oxygen supply as the baby that's at a normal sea level altitude. Does that make sense? Okay. Maybe a two vessel cord where you have less blood flow, so you have 2 arteries, 1 vein. Previa, again, because if it is implanted further down, may not have as good blood flow, because think about the lining of the uterus itself is made to allow blood to flow well through the placenta. But if you're on that cervical opening, is it going to have that endometrium there for it to attach to and have as good blood flow? No. Okay, because you're going to have that cervical opening that's not going to have the endometrium. Okay, so it can affect the blood flow. Other factors we might see is infection. So our TORCH, does anybody remember what TORCH stands for? Toxoplasmosis. Other, so any other kind of viral or bacterial infections that it's exposed to. Rubella. Cytomegalovirus. Herpes. There you go. Those are your infections that potentially, if baby is exposed to, because they can cross the placenta or make its way up the cervical os into that chorion and amnion, then it could cause issues with baby. So complications, most frequent complications that you're going to see is fetal hypoxia. When they suffer from a chronically lower than normal oxygen level in utero due to placental insufficiency, this is going to cause some fetal hypoxia. Okay, so we're still talking about those small babies. Aspiration syndrome, so hypoxia causes fetuses to gasp in utero, resulting in aspiration of amniotic fluid into the lower airways. Also may lead to relaxation of the sphincter and meconium passage, leading to aspiration of meconium in utero or at birth. So more so related to as soon as they're born and they have that fluid inside their mouth and nose and they gasp, okay? Because if you gasp, do you take a small or a deep breath? A deep breath. So it's going to pull that fluid further down into those lungs once they're born. They take that big gasping breath, okay? So that could cause aspiration syndrome. Hypothermia, so diminished sub-Q fat, so the depletion of that brown fat that they have, decreasing ability to conserve heat as a newborn. Hypoglycemia is going to be your most common complication, okay? And this is due to an increased metabolic rate because of heat loss and poor glycogen stores in the liver. Another complication is polycythemia. What's polycythemia? Okay, so polycythemia, we've got an issue with our RBCs. So our RBCs are increased due to hypoxia, which leads to hypoglycemia. Okay. Poor prognosis and outcomes for newborns with significant SGA or IUGR is expected, especially before 37 weeks. So we could potentially see congenital malformations. So more severe the IUGR, the greater risk for malformations. Intrauterine infections. So if they are exposed to rubella or cytomegalovirus in utero, they're affected due to an invasion to the brain or other organs by the virus. And they're going to have continued growth difficulties. They may be shorter than other newborns at the same gestational age. Potentially have cognitive disabilities later in life. So learning disabilities, hyperactivity, short attention span, poor motor coordination, hearing loss, and speech defects. So our nursing diagnosis related to these babies, okay? So hypothermia related to decreased sub-Q fat. Imbalanced nutrition, less than body requirements related to SGA newborns, increased metabolic rate. And why do they have an increased metabolic rate? They're trying to keep themselves warm. Okay, they don't have that sub-Q fat, that brown fat there. So their body's increasing their metabolic rate to try to heat up their body. Okay. Ineffective tissue perfusion related to polycythemia and increased blood viscosity. And risk for impaired parenting. Why impaired parenting?
They don't want to bond with it.
Maybe they're scared. Something's wrong with my baby. I don't want to hurt it. I don't want to touch it, make it worse. Okay. This wasn't what I expected. I expected to have a happy, healthy baby. And here I have this little sickly thing. Okay. So poor parenting related to inability to bond. Okay. Or maybe baby's in NICU. So they're not able to take those steps to really bond with baby because baby can't be touched or moved or taken out of the warmer. Okay. What are some nursing interventions that we are going to do? We're going to assess for gestational age. So we're going to do what's called a Ballard score or Dubowitz. Okay. This is something that not every facility uses unless you have a baby that is SGA, IUGR, or LGA. You're going to see what do they actually measure out to be. So on your, if you got to do a newborn care plan for OB this year, there was a Ballard score on there where you had the different things where you look to see how far down baby's wrist would go, what was their lie in the bed, what was their hip, like where, how far up could you move their hip, how far over could you do their arm, this scarf, okay? All that measures and all the points you add together and tells you about what the gestational age, how big their nipples were. If it was female, were the labia open, closed, butterflied? If it was a male, were the testes descended, or what did the rugae look like? Okay, all those things add up to create what would be your actual age of gestation. Okay. Signs and symptoms of complications. So, you know, we're going to assess for respiratory compromise. We're going to be checking for hypothermia. We potentially are going to look for signs and symptoms of hypoglycemia, and therefore we might have to assess a blood sugar. We're going to assess weight gains and follow their feeding. Okay. So which is priority for a long-term follow-up with an SGA baby? Monitoring blood glucose levels, evaluation of growth patterns, referral to developmental experts, or follow-up by the Student Nurses Association. Which one do you think is the most appropriate? Okay, so we have a baby that's born small. We're talking about long-term follow-up. So once baby's gone home and has their checks with the physician, which one of these do you think is priority? Do we need to monitor their glucose levels? Not necessarily, because we don't know if it's diabetic mom or if we had any glucose issues. Doesn't mean they have it just because they're SGA. Do we need to refer them to developmental experts? Maybe eventually, but not immediately. Okay, that's not something we need to worry about in that first year of life. Okay. Which one of you in the Student Nurses Association wants to follow this baby for the next 5 years?
Nanny.
Nanny. Okay, that's okay. Nanny might want to. So now the most important thing for us to do is evaluation of the growth patterns, right? We need to make sure and see that baby's gaining weight, baby's growing in length, okay? We're meeting those milestones in growth, okay? I love this picture. So here you have two babies that are the same gestational age, okay? Born on the same day. Okay, I did too. I had the first one. Okay. So look at this baby. You've got an SGA baby and an LGA baby. Look at the difference. Okay, and I wish we had one that had an average baby right in the middle. But you have a baby, two babies born on the exact same day, same gestational age. Look totally different. Okay. So an LGA baby is a baby that is in that 90 percentile or greater. So the risk factors that we have related to potentially having an LGA baby or large for gestational age would be diabetic mom. Okay. Genetics. That's why we ask sometimes how big were you when you were born to the mom. Okay. Multipara, if this is not her first baby. Boys tend to be bigger. Erythroblastosis fetalis, Beckwith-Widman syndrome, and transportation of the great vessels. Okay. Multipara moms are actually 2 to 3 times more likely to have an LGA baby And with the Beckwith-Widman syndrome, it's a genetic condition associated with macroglossia, omphalocele, which we'll talk about in a little bit, and newborn hypoglycemia, hyperinsulinemia. So what are some complications that we're going to see with these LGA babies? Potentially birth trauma related to CPD. Somebody can remind me what CPD is. Cephalopelvic disproportion, where we have a pelvis that the head's not going to fit through. Be it that the head's too big or the pelvis is too small, one or the other, okay, or both. So we could have asphyxia. We can have a shoulder dystocia. So this is where the head can make it through that opening. It's just big enough for the head, but once we get to the shoulders, which are broader, we have them get stuck on that pelvic bone, okay? So they have a big risk of fractured clavicles, okay? And possibly a humerus. Facial paralysis, skull fractures, cephalohematoma, or intracranial hypertension, where they got too much pressure in their brain, okay? So when we have these babies born, our biggest thing we need to remember is what maneuver are we going to use? I heard it. Say it. McRoberts, which means we're going to do what? Knee. We're going to pull those knees all the way up to those mama's shoulders. And then somebody's going to jump on her and do what? Suprapubic pressure, right? Why are we doing that right above that bone? Help push the shoulder under, right? We got to get that shoulder under. So that's where our risk comes for that fractured clavicle and humerus, okay? Is from the actual you pushing, or just as it comes through, it has to break to fit, okay? Facial paralysis, and then also these babies are at risk for brachial plexus nerve damage, which is the nerve that runs down your neck to your arm, okay? So with these babies, they are probably going to potentially have cesarean births. We're going to hope doctor is following that growth and then kind of makes that educated decision with mom on doing that versus a vaginal delivery, unless she has a proven pelvis and has already had a bigger baby, okay? If she's already had an 8 or 9 pound baby, she probably can do it again, okay? I think the biggest baby I've ever known in my career that I had in my office setting when I worked at Dr. Mesko's office was a 14 pound baby that was delivered vaginally in a precipitous way. I mean, this baby, she came super fast. Like we're talking like as soon as baby was born, like crowning, out she came, okay? And she came so fast, her poor face was blue. It was so bruised because of that baby coming down that pelvic bone so quickly. So hypoglycemia is a big deal, polycythemia, and hyperviscosity of the blood, because they could have polycythemia, okay? Care of a large for gestational age infant, we're going to monitor their vital signs. We're going to assess for hypoglycemia, screen for polycythemia. How would we screen for polycythemia? Huh? Blood work, but what blood test specific? CBC, complete blood count, because does it count our red blood cells? Yeah. See, y'all thought I was asking a trick question. But it wasn't. It was a simple one. Okay. So we're going to assess for signs and symptoms of birth trauma related to clavicle fractures, facial paralysis. Even sometimes they're going to have a dead arm, like you're going to see an arm that's not going to be moving and pulled up. Okay, that's that brachial plexus. Encourage bonding, especially those with face or head or birth injuries or bruising. Okay, these moms are going to be scared because that face is going to be purple. I showed you a picture of JC on the last lecture I did, and the first picture, that picture, she doesn't look too bruised. But pictures later through the day, her bruising gets worse and worse on her face. And it wasn't so much because she came so fast, it was because I got her to where I was about to deliver, and the nurse tells me to stop pushing. It takes 20 minutes for my doctor to get to the room. And I was the nice person, being the labor and delivery nurse, knowing that it's not fun for the labor and delivery nurse to have to deliver the baby. I was like, okay, I'm gonna wait. And then it caused JC to have bruising on her face, this poor baby. So complications of infants of diabetic mothers. Okay, so again, hypoglycemia. Anything less than 40 is abnormal for a newborn. Signs and symptoms are going to show up within 1 to 3 hours. So let's talk about some signs and symptoms. What are we going to see? Jitteriness. What? Pale, maybe not so much with hypoglycemia. That's coming more so with polycythemia or anemia. No sweating usually. What?
Hypothermia.
Hypothermia, because those kind of go hand in hand. What's the respiratory rate going to be like? Increase. They're going to have rapid respirations. Okay. They're going to possibly have lethargy. They're going to be sleepy. Okay. But your biggest sign is going to be they can't maintain their temperature, and they're going to show signs of respiratory distress. Okay. Rapid breathing, grunting. They're going to have retractions. So we have to assess a blood sugar initially, and then go from there. If it's within normal limits, something else is going on causing, which could be then hypothermia. So treatments, we're going to do a glucose every hour for 4 hours, then every 4 hours times 48 hours. Now this protocol can change from facility to facility, but this is your typical protocol, okay? You're going to start feedings early, okay? If you know mom's diabetic, as soon as that baby's born, if she's breastfeeding, we're going to encourage her getting baby to breast as soon as we can, okay? We're talking, don't remove that baby from the belly. Do everything on the belly. As long as baby's breathing well, you're going to give vitamin K, erythromycin, because you can measure that baby later, okay? We're going to leave that baby skin to skin, so that way it stimulates that urge to suck and root, and then put that baby to breast. Now, if a baby cannot maintain their blood sugar with feedings, then they potentially are going to have to be put on D10W, and we're going to have to do 6 to 8 milligrams per kilogram per minute. Probably a good thing to know for your test.
If they can't feed?
If they can't feed, yes. Yes, Manny?
What is the deal with, I know above 40.
You want above 40, below 100. I mean, you're going to get sometimes a little over 100 if they're on D10 or if they just fed, but that's when we need to let the physician know, and then reassess, do we need to knock down the IV fluids, especially if they're starting to feed and have the fluids going. Do we need to go to D5? Do we need to decrease our rate? So hypoglycemia, or sorry, continued complications with diabetic moms. We're going to have possibly also hypocalcemia, which is less than 7 milligrams per deciliter. Tremors. Rarely is treatment needed on baby for this. Possibly hyperbilirubemia. Okay, this is going to be about 48 to 72 hours. We're going to assess their what their bili level is. They potentially are going to have to then have phototherapy, the lights. Birth trauma because of big babies, that clavicle fracture, subhematoma, asphyxia. Polycythemia, which then results in hyperbilirubinemia. Okay, so if they have polycythemia, we can expect that they're going to have jaundice. Respiratory distress syndrome, so tachypnea, grunting, retractions. Potential for congenital birth defects due to the GI or skeletal system, and maybe cardiac malformations. With a GI, we could potentially see small left colon syndrome or duodenal atresia. With the skeletal system, we could be seeing sacral genesis or hemivertebrae. That sacral genesis is the more common one. So a big baby is not a mature baby. Okay, just because it's big doesn't mean that it is mature. So we're going to assess for respiratory distress, hyperbilirubemia, birth trauma, any possible congenital anomalies. We're going to monitor for the blood glucose. We're going to check a hematocrit for polycythemia, educate on baby's health and the need for diabetic control in mom. Okay. That's why if you have a diabetic mom, when we talked about pre-pregnancy things early in the maternity part, we talked about that pre-pregnancy counseling, talking about what do we need to do if you have a diabetic mom. They need to control that blood sugar, because if the blood sugar is not controlled, then it can cause issues with baby. So we need to make sure they understand that for future pregnancies, especially if we see a complication now in this pregnancy, we need to make sure we kind of educate about the next pregnancy. So how often should blood glucose levels be done on our baby? Our insulin dependent babies that mom was insulin dependent. Every hour for 4 hours. Every 4 hours for 48. Okay. And this is by our book. Of course, like I said, the policy is dependent upon your institution. Okay. At what blood glucose level should an intervention be done?
40.
Under 40, yes. And so what kind of interventions are we going to do? Feed. If that doesn't bring up the blood sugar, what's our next thing? D10W via IV, okay? Or potentially umbilical catheter if baby had to be recessed and there's one in place. So our post-term newborns, okay? So after 42 weeks, we can have a baby born. This could be also due to possibly an accurate due date. Okay, maybe she had late care, and when they did that early scan at 18 to 20 weeks, it measured, 2 weeks behind what it really was. And so now we think we have a term baby, but really it's a post-mature or post-term baby. So some babies born are going to be normal size. Some can keep growing and maybe up to 4,000 grams, which means that they were well nourished in utero. And then you have some that may come out smaller than they really were. They've already lost some of that brown fat because that placenta has started to shut down. It's not working as well. And therefore their nutrition is not as good through that placenta. So post-maturity syndrome. So we kind of talked a little bit about it in our lecture on labor earlier. We're going to kind of go a little bit more in depth. So hypoglycemia, they're going to have depleted glycogen stores because that brown fat's not going to be there. Meconium aspiration due to hypoxia in utero and you have a distressed newborn. Usually oligohydramnios is also going to get worse. So therefore, if they have a bowel movement, then that fluid is going to be thicker with meconium than if it was normal fluid. Polycythemia due to hypoxia. Congenital anomalies, and we really don't know the cause for them. Seizure activity due to hypoxia. And cold stress due to the loss of that sub-Q fat. So the post-term infant begins losing weight but has normal lengthened head circumference. And this is if that placenta is not functioning still good, okay? Or is not functioning good. If it's functioning good, you're gonna have a big baby. If it stops functioning, then that baby's gonna start to lose weight. But they're still going to have that lengthened head circumference, just like a post-term or normal baby would. So combination of advanced gestational age, placental aging, decreased placental function, and continued exposure to amniotic fluid is the reason that you have those babies that are peeling and have lost weight, all those symptoms we see, okay? Morbidity and mortality is 2 to 3 times more likely than a term infant. So your risk for stillbirth increases in these post-mature babies, and their risk for having complication affecting their morbidity is greater once you reach that post-maturity. So common disorders associated with post-maturity syndrome is decreased nutrition and oxygen. So they're going to have hypoglycemia and hypoxemia with labor. Meconium maceration due to intrauterine hypoxia. So at birth they do that gasping. Oligohydramnios increases the risk of aspirating thick meconium, which may lead to persistent pulmonary hypertension, pneumothorax, or chemical pneumonitis. Polycythemia, it increases the RBC production in the response to hypoxia. Congenital anomalies, we really don't have a known cause for seizures due to hypoxic ischemic cerebral insult, and cold stress due to reduction of subcu fat. So assessment of post-maturity. These babies are going to have dry, cracking, peeling skin, long fingernails. You're not going to have vernix or lanugo. So that vernix is that white, cheesy material that babies are born with sometimes, which protects their skin. But then around 38 to 40 weeks, it starts to reabsorb or slough off. So they're exposed then more to that amniotic fluid, and that's why you have that peeling. Meconium staining, which can occur anywhere on the skin or the umbilical cord. The body is long and thin with subcu tissue depleted. So what problems are you assessing for in these newborns? What's ABCT stand for? We have our ABCs, which is airway, breathing, circulation. What's our T? Thermoregulation, temperature, okay? Because these babies, if their temperature is low, are at bigger risk, okay? We're also going to be looking for hypothermia, hypoxia, respiratory distress, hypoglycemia. What are we going to do as a nurse? So, of course, the doctor is going to diagnose, is it hypothermia, imbalanced nutrition, impaired gas exchange, ineffective tissue perfusion. But of course, as the nurse, we may recognize it before the doctor can diagnose. So we're going to let the doctor know, hey, I think she has hypothermia. Her temperature is 97.2. I can't get it above 97.2. She's been under the warmer for 2 hours. Okay. And that's when the physician's going to then diagnose that hypothermia. Same with the others. So what are some interventions related to these diagnoses? Warmer, okay. Temperature we can't maintain, we're going to keep them under the warmer, okay. What about for impaired or imbalanced nutrition? Possibly, if they're not nursing well or not good feeders because of something going on, we may have to put an OG or an NG down and give tube feedings that way, okay. Maybe switch the formula to sensitive or even a higher calorie. Okay, we may have to do 24 or 30 cal. Smaller babies especially, they need that higher calorie intake to be able to build and grow that fat and nutrition that they need. Okay, impaired gas exchange. What's our intervention for that? We're going to resuscitate them. We're going to give them oxygen, right? We're going to do our BiPAP or CPAP, or even may have to do actual breathing for them. Again, same for ineffective tissue perfusion. If they're not getting the OT, we have to intervene and make them breathe and get that oxygen in.
Do they have ventilators for babies?
Our ventilators that we have at the hospital have settings for neonates, pediatrics. Yeah. So like if we have a baby we have to intubate, respiratory brings one down, so we bag it until the respiratory gets there with the ventilator. So, yep.
So when you fly them out, like, do they take the ventilator, or
They bring their own. Yep. If you ever are there when they come in with a baby that has to be flown out, it's like a gurney, and it has like an incubator on it, and then it has the vent beside it. I mean, it's a whole setup that's created specifically for those ill babies to be transported. All the monitors and everything you need, and it comes on a gurney. So they switch everything over to there. And usually like as soon as your flight team or crew gets there, you give report, that's basically like you're handing over that newborn. So you document that you gave report and that's when your documentation ends. Like you don't have to document anything that they're doing. That's their responsibility from that point on because they're taking over care of that newborn. Now, of course, you're still gonna probably have to get supplies if they don't have it available or whatever they need. But it's just like if you handed it off to another nurse on the floor.
Do you have to do that with mom if she decides to go with baby too, or?
Yes, but most of the time, once baby's born, they're not gonna fly mom and baby together. Yeah. Mom will have to usually stay depending on how well she does, and then it's discharged unless she's sick and needs to be out too. But they'll still fly them separate. Okay, so treatment and care for these babies. So we're gonna do antenatal testing, evaluate the fetal status, potentially an amnio infusion because if they have that super thick meconium or they're having variable decels repetitively, we want to increase that fluid volume around baby to decrease that compression on the cord and thin out that meconium. Monitor for hypoglycemia. We want to initiate early feedings, thermoregulation, and give oxygen for that respiratory distress. So now we're going to talk about the preterm babies, itty bitty ones. I read an article last week of a baby at 20 weeks that survived. He was born in July.
Oh.
20 weeks. That's crazy. Crazy, okay? So preterm infant, because most of the time, 23 is the youngest before 22, 23, I think was the youngest before that. But you're talking, I mean, 34, 35 weekers years and years and years ago were non-viable if you did not have a way to intervene. So after 20 weeks and at or before 37 weeks, that's considered a preterm baby. Okay. Look how tiny it is. It's as big as that mama's hand. Isn't that crazy? Or daddy's hand.
So what's the protocol here, Amanda, for a baby that's like 22 weeks?
So if it's 22 weeks, then what we usually will do is we will call the pediatrician that's on call or the pediatrician they selected, let them know what the baby's gestation is. A lot of times they'll come in and be there at delivery, and it kind of depends on the weight. Like we have an actual policy. Most of the time they have to weigh at least 500 grams or be 23 to 25 weeks. But if they're 22 weeks and they weigh greater than 500 grams, because we know that dates can be off and vary, then we're gonna resuscitate if parents want us to.
So I know when I had my clinicals at Garden, their NICU was they don't keep anyone under, I think she said 32 weeks.
Yeah, at their NICU.
So what's like policy here? Having no NICU. Like,
So if they have to be intubated and require assistance that way, then, and they have to be 34 weeks. We don't keep anyone under 34 weeks here if they require that extra care because we're only a level 2 nursery. So we don't have the accreditation to be one that keeps babies on ventilators because we're not a NICU. We don't have the staff that is trained to do those types of babies. And so we will stabilize babies and keep them stable until the team gets here and is able to take them to whatever facility we get them into. So, but yeah, we can keep babies here on oxygen as long as it's not intubated and it's maintaining its own. But if we kind of get to day 2 or 3 and baby's still not recovering, and there's not much more we can do in our facility, because we can give antibiotics, we can give O2, we can do OG feeds, you know, we do those things. But if we kind of get past that window, then we're going to probably ship them off to a more specialized facility. So, because usually after 24 to 48 hours, you're past that respiratory distress transitioning time. So now we know something else is going on. Is it cardiac? Is it kidney? Is it liver? You know, something else is going on that we aren't going to be able to help with in our small facility. Okay, so complications for these little babies. Okay, we can have cardiovascular respiratory. They are at risk for respiratory distress. One kind of leads to the other when you have a respiratory or a cardiovascular issue. Okay. Their lungs are not fully mature until about 37 to 38 weeks gestation. They're unable to produce adequate amounts of surfactants So they have hypoxemia and energy depletion due to trying to keep up their oxygen level. Their musculature of the pulmonary vessels are not completely developed, causing left to right shunting in the PDA. It increases blood flow back into the lungs. So it kind of flows back into the lungs, leading to pulmonary congestion, which increases respiratory effort, CO2 retention, and bounding pulses. They have their ductus arteriosus sometimes will not close so that it's open. Thermoregulation, heat loss is a major problem in preterms. They have a high ratio of body surface to weight. So they're pretty big, but they don't weigh a lot. Okay. And so because of this, they lose temperature quickly. So loss of heat in a preterm infant of 1,500 grams is 5 times greater per unit of body weight than an adult. Okay, so they're going to lose theirs faster. Thin skin contributes to water loss in addition to heat loss. Posture contributes to heat loss because they're not going to be those babies that like to curl into themselves. They're going to be like laid out, splayed out. Okay, because they don't have that natural, they've not gotten big enough in utero to start that fetal position. They're still able to move around. Okay. Preterms has the ability to vasoconstrict superficial vessels and conserve heat to the core. So they're going to keep their core heated, but they're going to lose their temperature in those extremities. Okay. Gastrointestinal, they're going to have a poor suck swallow. So ingestion, digestion, and absorption problems. They're going to be at risk for aspiration due to poorly developed gag reflex and poor suck, swallow, and breathe. Their stomach is small, so they have difficulty meeting caloric needs required for a preterm. They have feeding intolerance due to necrotizing enterocolitis because of decreased blood flow and tissue perfusion to the intestinal tract. So their intestines can die, okay, very easily because they don't have enough blood perfusion to those organs. Renal problems, difficulty filtrating and excreting. Urinary output should be monitored carefully, especially when receiving antibiotics like Gent and Bank, because they can become toxic and are at risk for excessive fluid overload. So we definitely need to be doing those peaks and troughs on those babies that are on Gent. And our go-to antibiotics on a baby is AMP and Gent. That's what almost every baby gets if they have to have antibiotics post-delivery for any reason. Like if we suspect a bacterial infection or they were exposed to GBS, mom didn't get enough coverage, then they're going to be on antibiotics and it's going to be AMP and Gent. Okay. Potential hematological problems. So their total blood volume ranges from 80 milliliters per kilogram to 100 milliliters per kilogram. So any blood loss is significant in a preterm baby. So we are still going to do some periodic lab work, but we have to be very careful on the amount of blood we draw. Okay, because their blood volume is very minimal.
You can draw again, like which one's which?
So a peak is going to be drawn at usually an hour before, like it depends on the dose, like 3rd or 4th dose. And then trough is usually done 8 hours after that 3rd to 4th dose. Yeah. So you want to see what your peak gets to, and then you want to see where your kind of average gets to. That's what a trough is. Okay. And if we have too high of a peak, then we know that we're getting close to toxic, or if our trough is staying elevated, which could mean that maybe because their kidneys and livers are immature, they're not going to metabolize as quickly. So they're going to be at a bigger risk of developing toxicity related to Gent because of that reason. Okay, so complications of the immune system. We could potentially have sepsis. Okay, so prematurity is the most significant risk for sepsis in an infant. Risk of infection from mom in utero or during the labor process. Passive immunity normally occurs in the last trimester. So that means mom gives over those antibodies to baby, usually in that last trimester, okay? IgA is found in the breast milk, so it helps protect newborns from enteric infections that are caused by E. coli, Shigella, because it coats the mucosa of the GI tract. So why does the preterm infant lack antibodies? They haven't been exposed to anything. Right, they don't have an immune system. They haven't needed to build up antibodies yet, right? They're in a sterile environment. So they haven't needed to build up any type of antibodies. So they have limited exposure in the third trimester depending on gestation, and IgA does not cross that placental barrier only in breast milk. But there are a few things that we do know cross antibody wise. They're smaller. Let me know what those are. What is one vaccine we do give in pregnancy? We do give the flu, but it's specifically related to being pregnant. Tdap, because we know that pertussis is going to cross the placenta and help protect baby. Baby is going to start developing antibodies against the pertussis. Pertussis is something that's very risky if baby gets exposed to early on, they can die. Okay. Somebody know of a recent vaccine that we've seen babies born with antibodies post-delivery? COVID. Yeah. If mom had COVID in pregnancy or received the COVID vaccine in pregnancy, these babies are being shown to be born with COVID antibodies. So they do cross the placenta, okay? But not all antibodies do. So that's why we encourage moms to then breastfeed as soon as baby's born, because that increases their ability to start building more antibodies because they get those antibodies from mom, okay? Even if we can get mom to just breastfeed the first few days. Colostrum for a few days is better than none, okay? So skin surface, so it's thin, transparent, and it tears easily. You're at increased risk for infection and developing bacterial sepsis. Good hand washing is a necessity, okay? Anywhere in life, people, just wash your hands, please. Please, please, please. Again, I watched another TikTok video because that's what I do when I can't sleep. I have a mom who had a baby in the NICU, and a resident comes in and was going to assess her baby, and she's like, stop, hold a minute. Did you wash your hands? Because he didn't, okay? That's good. She's like, I know you're the doctor, but I don't know what you just touched or where you just came from. So you need to wash your hands. Okay, hand washing is essential, especially with these babies. They have no immune system, okay? They can have bacterial sepsis, and sepsis for them happens rapidly, okay? Their bodies are so tiny, it doesn't take much bacteria in that bloodstream for them to get septic, okay? And so the onset is going to be quick, and you're going to see apnea, bradycardia, metabolic acidosis, okay? Neurological problems, the closer the newborn can be to term, the better they're going to have in the prognosis, because rapid brain growth and development occurs during the third trimester of pregnancy. The sucking, muscle tone, and states of arousal are weaker than in a full-time or full-term infant. And that last step in our neurological development in utero is the development of the myelin sheath. What does the myelin sheath do?
Do the electrical signals to the body like
Right, so it covers those nerves and is what helps those impulses go through, okay? So a big risk for preterm infants is intraventricular hemorrhaging and intracranial hypertension, okay? Which is a common problem for neurological complications. So these babies are going to have a risk for having bleeding on the brain and increased pressure. They're also at risk for hydrocephalus. So that tissue surrounding the brain and the head is so thin and those vessels are more exposed, it's going to cause the risk for increased ventricular hypertension. Okay. Or intraventricular hemorrhage. So nutritional needs. So it is with an uncomplicated preterm. So this is a baby that doesn't have really any complications. Their need is going to be 110 to 140 kilocalories per kilogram per day. Early feedings are important for metabolism, and it decreases the risk for hypoglycemia. Fortified breast milk and special formulas are used to meet the caloric needs. So the feedings are based on weight and stomach capacity. If they're unable to tolerate oral feeds, then TPN is ordered. Okay. So their nutritional intake for adequate weight gain is 20 to 30 grams per day. That's their adequate weight gain. That's what we should see them gaining every day, is 20 to 30 grams. So how many calories does a preterm infant who weighs 1,500 grams require for 24 hours? So it's 1.5 kilograms. So we're going to multiply first 110 by 1.5, which is what? 165. And then we multiply it by 140, which is 210. So if I were to give you a math problem like this, I would want you to give me a range. Okay. For that day, in that 24 hours, they need to have 165 to 210 calories per day. So then if I said we're going to have 6 feedings a day, how many calories per feeding? What would you do? Divide both those numbers by 6 and give me the range of calories per feeding. Does that make sense? Okay. Hint, hint. Other nutritional supplements a preterm infant requires: protein, vitamin E, multivitamins, polyunsaturated fats, calcium, and phosphorus. Okay. And we're going to kind of talk about things we need to watch for when it comes to protein in newborns here in just a little bit. So criteria for adequate nutritional intake, again, is 20 to 30 grams of weight gain per day, 15% or less total weight loss. And most of the time, the policy is going to be 10%. If you have a baby that loses more than 10% before discharge from the hospital, they're not going to be discharged until they've gained a little bit back. Okay. Just because we don't want them to be at risk going home and then not feeding well and losing more and more weight and then have failure to thrive. So growth in the body and the lengthened head, you're going to see about 1 centimeter per week in growth of the head and the length. Bottle feeding should only take about 15 to 20 minutes. And why are we giving them a time frame on how long they should feed? Right, they get tired. If they feed too long or it takes them too long to feed, they're using too much energy. Okay. And it's going to make them tired, especially if they're little like that.
What about your sister who was born in 32 weeks? And for like months, like you couldn't get her to stay awake to feed her the bottle. Yep,
and you had to work and work and work. Yeah, it's very common with those preterm babies that you really have to work with them to get them to feed and take in the adequate amount of calories because they just get so tired with eating. Other assessments during feedings, we're going to see, do they bring their hands to their mouth? Okay, do they have a coordinated suck, swallow, breathe? Are they sucking on a pacifier of their fingers? Are they rooting and looking for something to suck on? Are they alert and awake? Okay, these are all signs that those normal triggers that usually happens later in term babies are starting to occur in this preterm baby. Okay, because they don't have those natural instincts at that point yet to do those things to nurse and suck.
So would it be more beneficial for them to take like a high calorie formula versus breastfeeding?
Potentially, yes. A lot of times what we'll do is we will do, have mom pump and do a human milk fortifier. So it adds that extra calorie to the breast milk itself rather than giving them a formula. Yeah, we have human milk fortifiers it comes in a little package that we add to the breast milk, and then still we're going to bottle feed, and we may even do alternate feedings. There's different ways to feed babies. You don't have to just do bottle. You can actually then go ahead and put baby to breast and do like a kangaroo feed where you actually have devices that are made for it, or you can even use a little feeding tube with a syringe on it. And as baby sucks, you have the milk in the syringe, and they're going to pull that milk from syringe with that fortified milk in it, along with milk from mom. Or we can do cupping, which you actually put the milk in a medicine cup and kind of just tip it to their mouth like they're drinking from a cup, and they'll suck it from there, so they're not having that nipple confusion. You can spoon feed a baby with a spoon rather than using a bottle, so therefore you don't have nipple confusion. So there's lots of other ways to do it without having to put the nipple in their mouth, especially if you have a baby you're afraid going to have that confusion. So, and it takes a little bit more work, but if that's what mom wants, that's what we're going to do, because we want to be able to get that baby to breast whenever we can, and we don't want to cause issues later. Okay. So with gavage feedings, which is that tube, then we're going to probably start small and progress. Okay. You're not going to initially start gavage feedings at, 20 ml every feeding. Okay. We're going to start small and then increase as baby tolerates. Okay. So when we position babies for feeding, we're gonna lay them flat on their back, right? No. Okay. What would we do if we laid them flat on their back? Aspirate. Now, breastfed babies, of course, they're not always going to be in that semi-sitting position. They kind of are more flat, but because it's not a quick flow initially, they kind of have an easier way to suck swallow. Okay. Now, there are some moms who let down pretty quickly, and that milk will spray them, and you'll kind of have a baby gag. You'll see gagging once the milk lets down, and that's just because when it lets down, it sprays really quickly. But once it starts to slow down, they do better. But you want to do a semi-sitting position to prevent aspiration. We're going to look at them. Are they starting to breathe faster? Are they having signs of respiratory distress symptoms? Are we having hypothermia? Okay. We want baby skin to skin with mom, belly to belly. Okay, that's the best position. Even when you do football or across the chest. And we do want to unwrap them because that's going to make them more alert. But once they are latched onto the breast, then you're going to cover with a blanket to keep them warm. Okay. And being skin to skin is going to help reduce that risk for hypothermia. Difficulty in feeding. Are they having fast breathing? Do they desat? Do they have bradycardia occur? Are they getting lethargic? Is there that uncoordinated suck swallow going on? So when can breastfeeding start for a preemie? When they're engaged, okay? When they remain engaged in feedings, as soon as they demonstrate a coordinated suck swallow reflex and they have consistent weight gain and their body temperature can maintain itself outside of the incubator, then we can go ahead and allow that baby to start breastfeeding. Okay.
So for the would you recommend like alternating like breast like bottle feeding and then the tube feeding so they don't they call it burn calories too much or something?
It just depends. It depends if they're maintaining their weight with the bottle feeding, because normally we're going to probably usually start with a tube feeding on a preemie and then advance to the nipple. We're not going to initially start a nipple unless they're a little bit older, but those really early pretermers are always going to start with gavage feedings. And then usually it does kind of, what you do is you feed with a nipple first. After when you start to advance it, you feed with a nipple first until they start to get tired. If they haven't met their intake that we want them to have for that feeding, then we're going to gavage feed them. Okay. Because they do get tired. But usually don't alternate. Usually start with the nipple once we advance to that point, and then we gavage feed after. So with these breastfeeding babies, how long does it normally take for a normal, healthy baby to breastfeed? About 30 to 45 minutes. Okay. So we want to make sure that that's about as long as it takes for them, because again, we don't want to overtire them. Okay, they need to be within that 45-minute window so they don't get overtired. And of course, breastfed babies still need to be burped, guys. Okay, a lot of moms are like, oh, I breastfeed, I don't need to burp them. Yes, you do. Because sometimes with that initial latch, they're going to pull in air. Sometimes if they let go and then relatch, they pull in air. And so we need to burp these babies, okay? Again, I talked about cup feeding. This is where you have milk expressed into a medicine cup and the baby's able to kind of suck it out or lap it out with its tongue, okay? So I've mentioned gavage feeding, okay? This is a minimal enteral feeding, so just kind of like a tube feeding for an adult, but it's a smaller tube. Can go in the nose or in the mouth, okay? Most of the time, if it's going to be a little longer term, then you're going to do through the nose, okay? Like you would for an NG or a feeding tube for an adult. Gavage feedings are used for neonates who have poorly controlled suck, swallow, and breathe. They're sick or they're on a ventilator. May also need to be used if the nipple feedings are requiring too much caloric expenditure, increasing risk of aspiration. So again, we may start with the nipple feed and then finish with the gavage feed. Again, it can be nasogastric or OG. So that minimal internal feeding is a small amount of volume feedings of breast milk or formula to prime the intestinal tract. Benefits include stimulates hormones and enzymes of the GI tract, decreases the number of days on TPN, and it increases muscle maturation of the gut. Decreases the risk of necrotizing enterocolitis. So what is the proper procedure for gavage feeding? Okay, so you're going to use a 5 to 8 French tube. How do we check for placement? We're going to put a little bit of air, so 0.5 to 1 ml. Remember, this is a teeny tiny tummy. Okay, so you don't need much air to check for. Put the stethoscope over the tummy, and what should I hear? A whoosh, sudden gush of air, right, into this tummy itself. So when we go into feed, we're going to check for residual. Why are we checking for residual? How they're tolerating the feeding. Is it digesting? Is it going down? Okay. So we're going to look at the color, the consistency, and the amount that we have pulled back in. Then what do I do with this? Push it back in. I don't take it. I don't go throw it in the trash. I don't push it down in the sink. We push it back in, baby. Okay. We have to make sure we don't decrease our caloric intake by pulling out that amount and then leaving it out, because they're still going to digest it. Okay.
So gavage is just
Basically, yeah.
How do you determine if you want to go through the nose or through the mouth?
Normally you're going to go through the nose if you know it's going to be long term, at least for a day or two. Okay, because if it goes through the mouth, it's going to increase that risk for gag reflex. Yes, they're going to still kind of have a gag reflex with it in the nose, but it's more prominent with the mouth. You're usually only going to do the mouth as if you're suctioning out a stomach, or if you have a baby that all of a sudden you're having to do a gavage feeding on. But most of the time you're going to do an NG. So during the feeding, we're going to use a pacifier. Why do we think we're going to use a pacifier? Relax, but it also is going to kind of stimulate that suck swallow. Okay. Because they know they're getting fed, they can feel the tummy getting full, and it's going to stimulate that suck swallow. Okay. And so we're not going to aspirate because we don't have anything going in via the pacifier, but having the pacifier, one, is going to comfort, relax. It's going to help develop that sucking reflex and coordinate that suck, swallow, breathe. Okay. Okay, let's take a break until 10 minutes. Okay. So now we're going to talk about necrotizing enterocolitis. So this is a serious intestinal illness with these preterm babies. It's damage to the intestinal tissue that causes perforation, which then allows things to leak into the abdominal cavity, causing infection. So poop, basically. May cause scarring or strictures later on. They're going to have issues with absorption. Symptoms that you're going to see is abdominal distension, feedings that do not digest, bloody stools, bile-colored emesis, apnea, lethargy, bradycardia. They're going to need to have an X-ray to diagnose. So treatment for these babies initially is going to be an NG tube placement and oxygen, and they're going to have surgery, okay, to dissect that colon, remove the bad part out, and then reconnect. So fluid balance in babies, especially these little babies, okay? Hydration is important to the newborn and to the preterm. So adequate intake is based on weight, age, so gestational and chronological, and the volume of sensible and insensible water losses. So insensible losses can be minimized by providing a humidified oxygen, using heat shields, and placing the infant in a double-walled incubator. So this is like the loss that they could have from their skin, their heat loss. That's what an insensible loss is. So hydration status is evaluated and assessed. So we're going to look at signs and symptoms. So we're going to look at what is some signs and symptoms that you know of. Sunken fontanelles, okay. Poor skin turgor.
Do babies still have, would it be as obvious on their skin?
Yep, because I mean, think about their skin. It's pretty fresh and plump. Now, some of those pretermers that are skinny, it's a little bit more difficult. So instead of their arms, where's one place you can do it? Yep, you can do it on their chest wall, right above the sternum. Yep, okay. Loss of weight, so they're going to lose weight. Dry mucous membranes, just like in an adult. And decrease urinary output. So they can also have an increased urine specific gravity and hypernatremia. So weight change is the most sensitive indicator of fluid balance in the newborn infant. So what is one assessment that we can do, as you see on your picture? Weigh the diapers, okay? So we need to weigh the diaper before we put it on the baby, so we know the weight in grams. Once we subtract that from, so say we have 76 grams, our diaper weighs 16 grams. So that means we have 60 grams of urine, which is 60 mLs. Just like with our blood loss, grams to mLs is the same on urine, okay? So 1 gram equals 1 ml. So that way we know if they had 30 mLs of intake at one feeding, 30 mLs of the next feeding, 30 mLs of the next feeding, and then we had 60 mLs of loss, then that's probably okay, because we're going to have to retain some fluid, okay? But we can do our eyes and nose, what goes in, what goes out. So normal urine output for a newborn is about 1 to 3 mLs per kilogram per hour. So we're going to talk about with these preterm babies, kangaroo care. So kangaroo care is like skin to skin, okay? Mom or dad, you're going to put that baby skin to skin. It's going to facilitate bonding and closeness. This actually improves the baby's O2 saturation, enhances thermoregulation, and will stabilize vital signs. And this is not only in your preterm, but your newborn. If you have a newborn that kind of has some mild respiratory distress symptoms where you're not having to do any oxygenation, a lot of times if you put those babies skin to skin with mom, it stops immediately. Those symptoms disappear. Usually it's better on mom because they're going to smell mom's milk It's gonna help with milk stimulation. But I mean, if you don't have all moms in the OR and baby's doing this, a little bit mild, you could do it to dad too. But just that contact, that close contact, hearing that heartbeat, feeling that warmth of tissue from mom or dad, it's gonna help relax them, which is gonna then decrease those symptoms that they're having of respiratory distress. Therapeutic touch. This helps to stimulate blood and lymph flow. Okay. So we're going to talk about like stroking, gentle touch. So if you have a baby that necessarily is not going to be able to be held a lot, you still want to touch in the incubator. Now, sometimes if they're in distress and having apneic or high respirations or high heart rate, sometimes they will decrease the stimulation of touch for a little while to allow that baby to relax. Once baby's stable, then you're going to increase the touch, okay? It reduces motor activity, so it keeps that baby from wiggling. It's going to relax them because when they're moving, they're burning calories, okay? So therefore, it's going to reduce that energy expenditure. It's going to help weight gain to improve. It helps to regulate sleep patterns, and it helps parents interpret infants' expressions and behavior. So they're looking at those crying. Why is baby crying? They pee, they poop, they need to eat. Those things we look for in a normal infant, okay? So preterm newborn complications we may see. We could see a patent ductus arteriosus. So this is where that duct ends up not closing due to hypoxemia, okay? It prolongs an illness and leads to chronic pulmonary dysfunction. So what happens is that patent ductus arteriosus, it's a conduit between that left pulmonary artery and the descending aorta. Okay, so that's that higher opening. So it shuts blood away from the fluid-filled lungs because the lungs are not functional during gestation and sends blood towards the placenta for gas exchange. So in a healthy newborn, this usually is going to close around 72 hours post-delivery. So closure is related to birth weight, as symptomatic PDA increases with a decrease in birth weight. So the smaller they are, the bigger they risk of that not closing, okay? So really preterm infants, 30 weeks or less, may take several days to weeks for this to close on its own. Symptomatic PDAs occurs when the left to right shunt via the PDA occurs. So the blood flows from the aorta to the pulmonary artery, increasing pulmonary blood flow. It leads to left ventricular overload, pulmonary edema, and CHF. So we have a preterm infant that has immature lungs, that has hypoxia, that PDA does not close, so that blood flow from the aorta to the pulmonary artery is increased, so that increased pulmonary blood flow. We have left ventricular overload, leading to pulmonary edema, CHF, and respiratory distress. Okay, so we're going to see tachypnea, bounding pulses, you're going to hear a murmur, and you're going to have tachycardia and hypotension. So you're going to identify the symptomatic infants of a PDA as early as you can to minimize the long-term complications. So symptoms, again, that you're going to see are a murmur, respiratory distress, tachypnea, bounding pulses, hypotension and widening pulse pressures, tachycardia, hepatomegaly. Why would we see hepatomegaly? Think cardiac. Backs up, right. So if you have a right ventricular overload, it's going to cause blood to back up in that liver. Okay. Backs up in the veins, the GI tract, and into that liver. So our treatments, we're going to have adequate respiratory support, restrict fluids, and administer diuretics for pulmonary edema. DIG is used to help if CHF develops while waiting for the PDA to spontaneously close. So prostaglandin synthase inhibitors like indomethacin helps ductal closure by prohibiting prostaglandins that dilate the ductus, keeping it open. Okay. So just know that with those prostaglandins, the indomethacin, it helps that ductal closure by prohibiting your body's natural prostaglandin that keeps it open. It's an inhibitor. Indomethacin, PDA, going to help it close by causing those prostaglandins to be inhibited. Important concept to know. Indomethacin.
Same one that's used for gout.
Yep. So the dose for it is 0.2 milligrams per kilogram every 12 hours. 3 doses is standard, and it can be extended up to 7 days if needed. Ibuprofen lysine or neoprofen can be used to aid in closing the PDA. We know it is also a prostaglandin inhibitor, so it does the same thing. But our most common one we're going to see is indomethacin. The reason we don't use the neoprofen as often is because of the side effects of GI bleeding and oliguria. So it reduces the urine output and can cause GI bleeds. So a growing preemie with increased O2 needs, acidosis, and hypotension may have a PDA. So if you have a baby that's required more oxygen, they're in acidosis, and they have a low blood pressure, they're a bigger risk for, you're going to find that they have a PDA. Apnea is the cessation of breathing for 20 seconds or longer. Okay. Cyanosis, pallor, and bradycardia during any length of time. Most common in preterms that are less than 36 weeks. You can have obstructive apnea, which is the cessation of airflow associated with a blockage of an upper airway. So possibly due to improper body alignment, secretions, small airway. Okay, we had a baby this weekend that had small nares, plus it had some mucus. So she decided, I can't breathe, and turned purple, but we got her breathing again pretty quick. Okay, and so it just was related to a combination thing, smaller nares and mucus buildup. Okay, so you can even see this in healthy babies sometimes. Intraventricular hemorrhage, or the IVH, is the most common type of intracranial hemorrhage in small preterm infants that weigh less than 1,500 grams or they're less than 34 weeks. A cranial ultrasound is done to assess for this. The common site is in that lateral ventricles of the brain where most blood supply is and capillary walls are thin and fragile. Before 32 weeks, they're much more susceptible to hemorrhage of those vessels due to blood pressure fluctuations and hypoxia from the RDS or the respiratory distress syndrome or birth trauma. So when we have a preterm baby, what is your most common way it's delivered? Vaginal or C-section? C-section. And the reason is because we want to reduce that birth trauma, reduce that risk of IVH in the brain. Interventions, we're going to prevent premature birth. Hopefully, we're going to stop that labor from occurring. We're going to give steroids to mom. Betamethasone, how many doses? 2, how far apart? 24 hours. We're going to have initial dose and then 24 hours later. Okay. Usually it's 12 milligrams. We're going to do a C-section delivery. We're going to give phenobarb and vitamin K to mom. It's being studied to see if it's a preventative measure also of hemorrhage. Another one that we also sometimes will give is magnesium to mom, because that can reduce the risk of neural deficits in baby after delivery. Does anybody know what common neurological disorders related with preterm delivery? Cerebral palsy, CP, is your most common neurological disorder related to preterm delivery. So betamethasone is anything greater than or less than 37 weeks. Anything that's considered preterm, you're going to give betamethasone. From a viable age, 20 to 24 weeks, up until 37 weeks. So less than 37 weeks, they're going to get betamethasone. Initial and then 24 hours later. Hopefully, we can stop the labor. We're gonna make sure that we are prepared for resuscitation. We're gonna try to prevent large fluctuations in the blood pressure for baby. We're gonna correct any acid-base abnormalities slowly. We're gonna correct coagulation abnormalities, reduce seizures by giving, or the chance of seizures by giving phenobarb to baby. And of course, the outcome just really depends on that the size of bleed that baby does have. So another risk that we're gonna have is anemia. At risk due to the rapid growth rate required. There's a shorter RBC life. They're gonna have excessive blood sampling, and they have decreased iron stores and deficiency in vitamin E in these babies. The hemoglobin reaches its lowest level at 8 to 12 weeks and remains there for 3 to 6 months. So we're gonna have to give some iron supplements, erythropoietin to help increase that RBC development. Once discharged from the hospital, the newborn is going to follow up, and it's very important that they do it often. Usually that first year life, a preterm low birth weight infant has higher mortality rates than a term infant. They're 5 times more likely to die from SIDS. So newborn congenital anomalies you're going to see, potentially hydrocephalus. Hydrocephalus is when you have the obstruction and flow of that cerebral spinal fluid, resulting in ventricular enlargement. So it's a progressive ventricular enlargement. So you have enlarged full fontanelles, a split or widening sutures, and the head circumference is greater than that 90% growth chart. You're also going to see that those sun setting eyes, to where their eyes have so much pressure they have that look down. Choanal this is the occlusion of the posterior nares. So they're going to have cyanosis, noisy respirations, dyspnea during feeding, and obstruction due to possibly thick mucus. Another one is cleft palate. So on the lip, it could be unilateral or bilateral. It may involve the external nares, the nasal cartilage, or the septum. Could it involve all 3 or just one of those? Okay. Flattening or depression of the midfacial contour. So on assessment, it's going to be an obvious deformity. You're going to see it. Okay. Now that's why we assess the palate on a newborn. You'll see the nurse put a glove on and put their finger in their mouth because we're assessing their palate. I actually, when I worked in Guyman, we had a baby that had an abnormality, but it wasn't necessarily with the hard palate. It was the soft at the very back. She did not have a uvula. Okay. And we didn't know it until one day she was screaming, and my coworker was like, "She had a uvula," and I was like, "I don't see one." So we mentioned it to the pediatrician, and sure enough, that can be a soft palate, kind of like form of a cleft. So she never formed the uvula. So she had to be followed up by a specialist in Oklahoma City just to make sure there was no other anomalies, because usually if you have one, you have a potential for more. So we're going to assess the baby because it may not be visible. So nursing diagnosis for these babies, they're at risk for an ineffective airway, risk for aspiration, and ineffective feeding. So interventions that we're going to do are aspiration precautions. Why aspiration precautions? They may not, if they have a palate that's open, nares that are open, if they have a bigger airway, their epiglottis may not be able to fully cover over that trachea, and then you're going to have aspiration, okay? Feed with a special nipple or bottle, okay? These nipples usually are real long and wide, so that way, if the baby does have the cleft palate, then it's kind of helping occlude so baby can still breathe, okay? And you're gonna burp frequently because they're at risk of bringing in more air, okay? So the cleft palate is a fissure connecting the oral and nasal cavity, so there's an opening between the two. Assessment of the mouth and structures, so the uvula and soft palate can be involved. So again, like the baby had said, it had no uvula. Everything else was normal, but just didn't have a uvula. Hard palate may be involved. Sucking is difficult for the infant, typically expels formula through its nose. These babies are on aspiration precautions also. And interventions to consider, they swallow large amounts of air, so they need to be burped often, pretty much with every ounce or half ounce, and positioning when you're feeding them, okay? More a better upright, not just a semi-upright. So you could have a tracheoesophageal fistula, okay? This is an abnormal connection between the trachea and the lower esophagus. Sometimes with the mom, you're going to see in her history that she had polyhydramnios. Following delivery, these newborns display excessive oral secretions, constant drooling, choking, cyanotic episodes. They are an aspiration risk. They can develop aspiration pneumonia due to gastric contents fluctuating into the trachea, because remember they have an opening there between that esophagus and trachea. So if they have reflux, then you have a bigger risk of it going into the lungs. When we try to place an NG tube, we are unable to pass it because of a blind pouch of the esophagus, so it coils back up. Another risk is a diaphragmatic hernia. This is when a portion of the intestines have entered the thoracic cavity through an abnormal opening in the diaphragm. So this baby is at risk for what? What's your initial thought? Respiratory distress. Why?
The diaphragm's being affected.
Yeah, diaphragm's gone, so you've got bowels up here. Is it going to be able to expand its lungs and breathe appropriately? No, and your other risk is maybe those lungs didn't develop appropriately if it happened, you know, because they're up high early on, okay? So the newborn has difficulty initiating respirations. They're going to have gasping and nasal flaring. They're going to have a barrel chest. Breath sounds are going to be absent unilaterally. A lot of times it's on the left side. Heart sounds will be displaced to the right. And you're going to possibly hear bowel sounds in the lung cavities because, again, the bowels are up here, okay? So these babies, remember on the diaphragmatic hernia, they're a big risk for respiratory distress, okay? Because they're not going to be able to have that initial breathing episode because of they have no room to expand those lungs. Myelomeningocele, okay? So this is a sac-like cyst containing meninges, spinal cord, and nerve roots in the thoracic or lumbar area. There's no sensation or response to those lower extremities below that defect. You're going to have constant dribbling of urine or stool. And they may also have an anal wink.
What is that?
Essie's like, what is that? Okay, so you're gonna see that sphincter kind of open, close, open, close, open, close, open, close, open, close, open, close, open, close. Okay. And it's because it has no control. The brain's not being able to control it. Okay. Interventions, you're gonna cover that myelomeningocele. Let's say it slow. You're going to cover it to prevent drying and rupture. So you're going to use wet, sterile saline soaked gauze to cover it. We're going to administer antibiotics, AMP and GENT. So we're going to position them to prevent damage to the sac. So these are one of those babies that's going to have to go on their belly. Okay, but we're going to have to make sure we're watching to see babies not face planted into the blankets. Turn to right or left. Handle the newborn carefully to prevent rupture of the sac. You're going to diaper the newborn with a mud flap to prevent contamination. So you know what that means? Yeah, you're gonna like kind of turn it under, so that way hopefully it will kind of catch instead of, so you're gonna form like a fold over. So that way if poop comes up, it's not gonna go out the top, it's gonna kind of catch in that fold, okay? And we're gonna monitor for hydrocephalus. Here's a baby with a myelomeningocele, okay? An omphalocele, this is an abdominal wall defect. Okay, this is where the abdominal wall failed to close during development. The abdominal contents are herniated into the base of the umbilical cord, covered by a thin sac. Because did you know when the intestines are forming in your fetus, they actually form in that base of the umbilical cord and then come into the abdomen and it closes over when they're forming in those first 12 weeks. So sometimes you'll have babies that it doesn't close and the intestines did not go in, okay? The abdominal contents are herniated into that base. So we're gonna do antibiotics. I'm gonna put this baby on an NG tube. We're gonna maintain hydration and temperature. We're gonna put a sterile bag covering the defect and or sterile warm saline soaked dressing. And why do we want it to be sterile? Right, because we want to reduce the risk of an infection, okay? Maintain thermoregulation, maintain respiration. Now, we have gastroschisis, okay? Omphalocele and gastroschisis are different. So with your omphalocele, your intestines are inside the base of that umbilical cord covered in a sac, okay? Gastroschisis, these babies, their intestines are outside of their body. There's no sac covering it. They're just out, okay? So I want you to tell me what are some things about this newborn that we can assess and see, and what are some things that are potential risks? Okay, big time potential risk for infection. What else? Okay, maybe bowel obstruction and issues with bowels. Necrosis, okay. What about thermoregulation? These babies are going to be higher risk for hypothermia because not only do they have their skin exposed, they have a large amount of their bowels exposed, okay. So with gastroschisis, it's a full thickness defect in the abdominal wall. That viscera is outside of the body, okay? So there's no sac covering the intestines. These have been exposed to amniotic fluid. So we're going to place the newborn in a sterile bag to the axilla, or we're going to use saran wrap to cover. We're going to avoid putting pressure or smashing the bowel, and we are not going to cover with a wet saline gauze. Why? Okay, it's your bowel. So saline rapidly cools and it can contribute to heat loss. Okay, so we don't want to cause more heat loss. So we're just going to wrap in plastic wrap or put them in a little Ziploc bag up under to their armpits. We're going to maintain hydration, maintain their temperature. They're going to have an NG tube and they're going to also have antibiotics.
Also infections if you use gauze, because like the little pieces.
Potentially if they go inside, but it's more so related to we want to not cool them off too quickly. Okay.
Would you put them on a warmer then, or is
You would still put them on the warmer, but then you also have to be careful of your intestine. We've got to protect that too. So, you know, it's kind of a catch-22. You want to keep baby warm, but you don't also want to dry out the intestine. And they're usually going to have surgery pretty quick, within 24 to 48 hours after.
but like not here though?
No, these babies are going to be
How
shipped.
long are they gonna stay like?
Not long. They're going to be shipped. Okay, and they're usually going to have a short period of time to where, you know, they got to make sure there's no inflammation, and then go into surgery, make sure everything's normal with the bowel, and then go ahead and put it in and close it.
This condition is, you can see an ultrasound.
Yes.
So you were like the third
Most of the time, if like, say this was caught at that growth scan at 24 weeks, your doctor, your gynecologist, OB-GYN is going to probably refer you to perinatology or maternal fetal medicine, okay? And that way you can be assessed in pregnancy and make that birth plan of being induced or having a C-section or whatever the plan may be with these babies.
Is it hard to miss on scan?
It's pretty hard to miss because they're looking when they're doing the growth scan, the anatomy scan especially, they're looking at the stomach, they're looking at the kidneys, they're looking at the bladder, okay? So when they get there, they're gonna notice if it's a good ultrasound tech, they're gonna see the difference. They're gonna notice that there's something wrong.
Because when we were at Garden, they said that they had one the day before.
That was born with that. And you also, but you have to remember, it can be based on positioning. It also can be based on the skill of your person doing the scan. And plus two, when did she have her scan? Did she have a scan earlier, later? Did she have a scan at all? You know, so if you have someone who has no prenatal care and comes in and delivers, you're not gonna know if they have it or not because they've not had a scan, okay? But if they've had a growth scan at the appropriate time, this is gonna be caught more times than not.
So can they still deliver vaginally, or does that put trauma on the intestine?
I've seen them deliver vaginally, you know, it just depends on the provider and that, you know, what mom and provider prefer. Yep. So just remember on that omphalocele, it actually protrudes into the umbilical cord and it's sealed over, okay? Omphalocele, it's in a seal, okay? And then your gastroschisis is out and open, okay? Yes, my dolly.
So are those intestines out and that one you said has a bag?
Yep.
You can put,
And you can, and you can put gauze because there's
it's not gonna cause it to.
because there's a cover over the intestines. But on the actual gastroschisis, there's no cover. So there's nothing protecting.
That one's inside the umbilical cord.
The omphalocele is sealed in the umbilical cord. Okay, I'm a word association person, so that helps me remember. Okay, so it's got it, it's covered by the cord still, but it's still outside the body. Yep, outside of the actual abdominal wall. Okay. So prune belly syndrome. Okay. So prune belly syndrome is also known as Eagle-Barré syndrome or Eagle-Barrett, however you want to say it. It's the absence or severe weakness of the abdominal muscles. Okay. It's primarily seen in males. So it's an abnormal expanded bladder and problems with the upper urinary tract. It may also have heart, skeletal, or GI defects. A lot of these babies are born still or stillborn, or they die within a few months. Our assessments and interventions are usually going to see a sign of oligohydramnios. Why oligo? Because if they have issues with their urinary tract system, they're not able to pee and make more amniotic fluid, right? Okay. So they're going to have oligohydramnios. They're going to have loose, hanging, wrinkled skin or a shapeless abdomen. And on these babies, we need to maintain respiratory status. They're probably going to need to be intubated. Why? It's our stomach that's affected.
Or the tummy breathers.
Tummy breathers, right? Our newborns use their abdomen muscles to breathe. If they don't have muscles there or they're severely depleted or weak, they're not going to be able to breathe. Okay. So a lot of these babies, these prune belly babies, have to be intubated because they have no musculature to move to be able to breathe. Okay. Imperforate anus. So this is the absence of an anal opening. May have a fistula. On boys, the fistula is between the rectum and the urinary tract, scrotum, penis, or perineum. In girls, the fistula is between the rectum and vagina or the perineum. So on these babies, you're going to have no rectal opening. Muscles and nerves around the anus have not formed properly. They're not going to pass meconium. That's your biggest sign. Okay. After 24 hours, you're at 36 hours, baby's still not pooped. You're getting close to 48 hours, baby's still not pooped. Years ago, we would do a rectal temperature on the very first temperature, and that was to assess for an imperforate anus. But now we know sometimes you can see an opening, and there may be an opening, but if there's not anything behind it, so if you put a thermometer in there, what are you gonna do? Pierce through, okay, and cause more issues, okay? So that's why we no longer do a rectal temperature after delivery, okay? So you're gonna assess the rectum, you're gonna open up those buttocks, you're gonna look, can you see a sphincter that's there? Does it look normal, okay? And then our next assessment is, do they poop, okay? So no meconium passage, but don't be fooled, because if there is a fistula, you may still have some meconium passage, okay? But these babies are going to have gradual abdominal distension over time. So interventions are going to be inspect the anus to make sure it's patent, inspect for a fistula, which is going to be more so the physician doing, okay? Maintain fluid balance, and these kiddos may also require NG tube feeding. So some screening tests that we do on our newborns, okay? Phenylketonuria, or PKU. This is when you have a baby that is unable to convert phenylalanine, okay? So it's a protein accumulation in the blood. It can't break down proteins, okay? This happens in 1 in 12,000 births. You see a higher incidence in Caucasians. It's an amino acid disorder. So a newborn with PKU lacks the ability to convert phenylalanine to tyrosine, which results in the protein accumulation in the blood. So we call that form that we prick the baby's heel and collect 5 spots of blood on, we call that a PKU, because that is one of the main things we're looking for, but it actually tests for many more disorders, okay? But that is one of the main things. And why do we have to wait 24 hours to do that test? Okay, you're going down the right road. What did you say?
So the concentration can go up.
Right, protein concentration. You have to feed them something with protein, right? Breast milk formula, and then assess, is the body breaking it down? Okay, so exactly, you have to have enough protein in the system to be able to assess whether or not the body's breaking it down, okay? Now, sometimes if we do have a baby that's having to be transferred or shipped, we will still collect the PKU form before we ship them, even though it's not been 24 hours, just so that way we do have a sample to send off. And they may repeat it at the facility that they're at, but we need to make sure we at least have one that we can send in, okay? Another disorder is maple syrup urine disease. This is a metabolism error that can be fatal if untreated. So it's amino acid chain problem. So you're going to have feeding problems, seizure during the first week of life. Their pee is going to smell like maple syrup. That's why it's called the maple syrup urine disease. That scientist was very, very funny. It smells like maple syrup. Let's call it maple syrup urine disease.
Usually there's smell like that.
Yeah, their sweat can smell like that too. Okay. And an ear swab can smell like it. Okay, so any body fluid that your body creates, you're going to have that maple syrup smell. Okay. Homocystinuria. This is a skeleton abnormality. It's a deficiency of the enzyme cystathionine beta synthase. We treat this with high doses of B6. Galactosemia, this is a carbohydrate metabolism problem. The body cannot use sugars like galactose or lactose. It unusually high levels of galactose circulates in the blood, causing cataracts, brain damage, and liver damage. Symptoms that you're going to see is vomiting soon after ingesting milk, diarrhea, poor weight gain, and jaundice. They're going to have a galactose-free diet, so they're going to be like on soy formula. And never will get to enjoy cheese because they can't have galactose or lactose. Congenital hypothyroidism. These babies are going to present with like a large tongue, umbilical hernia, modeling. What's modeling? It's the skin, and so it looks like it has that patchy. They'll have like white with like a ring kind of around it, and it's the whole skin. That's modeling. Okay. Yes, you do see it when people die. You see modeling in the skin, but it can happen whenever they have this disorder. Okay. Infants less than 30 weeks usually have a lower T4 and TSH, so they are at risk for hypothyroidism. So they may have to be put on thyroid meds. So resuscitation, okay? Again, unless you work in OB or possibly ER, a lot of times you're not going to have a concern of needing to know how to do neonatal resuscitation, okay? But it's good to kind of have some ideas. So we're going to go through it. So first, you have to rapidly assess what's going on. Okay, so if you go into a resuscitation room as that baby's about to deliver, when I worked at Parkland, if we would call for the resus team, there was some things they would ask. What's the gestational age of that baby? Okay, is there any presence of meconium or infection? How many babies are there? And any other risk factors in mom? Okay, so these are things I knew I needed to be prepared to tell my neonatologist when they walked in the room. So an easy way to remember this is twins, term, or turds. Okay, word association, I told y'all. Okay, so is there multiples? What's their gestation? Is there meconium infection and any other risk factors with mom? Okay, after delivery, we're going to look, is the baby term? Is the baby breathing and crying? Does the baby have good muscle tone? That's where we get those APGAR scorings from. So resuscitation management for the newborn, we're going to clear the airway and stimulate that baby. So as soon as that baby comes out, if I ask you on the test, what is the first thing you do to the newborn once it delivers? We're going to clear the airway and we're going to stimulate them. Okay? You can clear the airway in different ways. We have bulb suction, but if you don't have that available, you can even use your baby blanket to kind of sweep the mouth out, okay? Maintain a good head position. We're going to assess that nose and mouth, and we're going to rub that back to stimulate that baby to cry, because what does that do when we stimulate baby to cry? Opens those lungs. It brings out that, it expands those lungs, pushes out that amniotic fluid. So you have a lot of people like, oh, don't cry, don't cry. You know, the dad's always like, don't cry. And I'm like, no, we want them to cry. Okay. That's good for us. It means that they're clearing their lungs out and they're able to breathe better. Okay. Because they're always like, oh, don't cry, baby. They're like flicking it on the foot, rubbing it on the back, and it's, you know, screaming. And the dad's like, don't cry. Like, no, we want it to cry. So we're going to immediately clear the airway and we're going to stimulate that baby. Always. Okay. If we have no respirations or an adequate effort to respirate, we're going to do positive pressure ventilation, PPV. Okay. We no longer use an ambu bag. In these situations, we use something called the NeoPuff. So the NeoPuff in our facility is actually built into the warmer. Okay. And it has settings that where you can't go above a certain pressure. Now, you can move it past that point if the physician requests you to do so. Say your pressure you're using at the max of the recommended is not working, you can increase it, okay? But it requires a physician order. So we're gonna start positive pressure ventilation. So we wanna do 40 to 60 breaths per minute because that's what our baby's normal range is. We're gonna put that baby in the sniffing position, just like you would an adult. Avoid hyperextension. We're gonna use the NeoPuff. In some instances, you may not have it. You may have to use that bag valve mask, but the pediatric ones for neonates have a pop-off valve, so it's not supposed to go above 30 on your pressure. Should work, because why do we not want to overpressurize this baby? Pop their lungs, causing a pneumo, right? We overpressurize, we're gonna blow that lung up and we're gonna cause a pneumothorax. So then we're gonna look for chest rise and a proper ventilation. We're gonna monitor our heart rate and pulse ox. So how do we assess the heart rate on a baby? There's 2 ways you can do it. Umbilical cord, I heard somebody say umbilical cord. So if you gently put pressure at the base of the cord, because that ductus has not closed, you should be able to feel the heart rate. Or auscultate at your heart, your apical, okay? If you do not feel the heart rate, then you're gonna do your apical pulse. Now, if you're sitting there counting, what is some way that your coworkers can know what that heart rate is without you telling them? Tap it, okay? So if you're feeling it, tap the rate. If you're listening, tap the rate. You can do your foot, you can do your finger, and that's gonna then allow them to know what the rate is. Because if I know what a 120, 130 versus 60, okay, can you tell the difference? I'm gonna know just from hearing or seeing that that's not a good heart rate versus a 4. Okay, so that's just a little tip. Okay, it's not on your test. It's a piece of information. Okay. So we're gonna monitor. We're gonna know. We're gonna feel the heart rate, or we're gonna listen. So inside the uterus, the baby's oxygen level is only about 60%. Okay. So if you throw on a pulse ox at 2 minutes, do we expect that baby to be 100%? No. The baby's not going to be 100% yet. It takes up to 10 minutes for a baby to get to 100% oxygenation. Okay. So if you look on our warmers, there's a little scale on there that shows you the minutes and what the oxygenation should be. Okay. I don't have it memorized. I just know by 10 minutes, it should be 100%. I know if I put it on at 2 minutes and I'm at 80-something%, I know I'm good. Okay, because it's above 60. So O2 at 21% to 100% to help raise that saturation up. So at 10 minutes, we should expect it to be about 85 to 95% to 100. Years ago, we would have a baby born. He'd be not the best color, but crying and happy. And we would still put blow by oxygen on it because we like pink babies. But then when I worked in Dallas, Sweden or Switzerland, I can't remember which country, had done a study to where they looked at kids who had developed childhood leukemia. One of the common factors that they saw between all these participants in this study was they all had received oxygen prior to 10 minutes of delivery, high flow oxygen. That wasn't always necessarily needed. So that was a pretty significant finding for them, that they made the recommendation that as long as baby's oxygenation is, and so then they started to study what is the pulse ox at 1 minute, what's it at 2 minutes, what's it at 3 minutes, the average. So as long as you're following that average, then baby doesn't need that supplemental oxygen, okay? Because that's a big enough significant increase in these children that almost 99% of them had received supplemental oxygen at delivery. What the link was, they still at that point had not found that it was enough to say don't give supplemental oxygen unless it was required. Okay. So a lot of times you'll have moms like, oh, the baby doesn't look pink. If they're screaming and crying and baby's just been born, so that's okay. It's normal up to 10 minutes. It takes them a little bit to pink up. So So we're gonna monitor pulse rate, we're gonna monitor our O2 saturation. Where are we gonna put our pulse ox on our baby? Right hand or wrist and either foot, okay? Because we want a preductal and a postductal, because it's not gonna be the exact same, okay? It can vary, especially in that first 24 hours as we're waiting for those ducts to close. So if our heart rate is less than 60 beats per minute and our O2 saturation is not increasing, we're going to start compressions. How do we compress a baby's chest? Either via finger, or we can circle the chest and use our thumbs and have our fingers behind it to stabilize. Okay. So we need to go 1/3 of the anterior posterior depth of the chest at a rate of 90 beats per minute. So it's a 3-to-1 ratio of the heart rate, assisted ventilation. So 90 compressions, 30 breaths per minute. Okay. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. Okay. So you got to think of your rate. If there's a song, it's going to be faster than an adult. Okay. We're going to do faster than an adult. So the doctor is going to come in, start a UVC. We're going to administer epinephrine. Can I administer epinephrine a different way? How? ET tube. I can give epi in my ET tube. Okay, the dose is going to be a little bit different because the absorption is going to be different, but I can do my ET tube if I still don't have a UVC in. Okay,
Double the dose, right?
it's about, yeah.
So what is UVC?
Umbilical vein catheter. Okay, umbilical vein catheter, where we actually put a tube into that umbilical itself, into that vein and into baby. That's your easiest and fastest access. You can push epi, you can give IV fluids, you can give antibiotics. Through the umbilical cord, through the umbilical vein. Yep. We're going to consider intubating these babies if they're not recovering quickly. Okay. And again, we could administer our epi through the ET tube. So our dose on the UVC is 0.1 to 1.3, but in the ET is going to be 0.3 to 1 milligram of your epinephrine. Okay. I'm not going to have you know the dosage. Okay. Because even us who do it often, we have our sign in the nursery that we use to, okay, let's remember how much epi can I give? And it's based on weight. Okay. And of course, it's sometimes a guesstimation because we don't have time to weigh the baby. We just have to kind of guesstimate the weight. So a cold stress newborn. So this is a normal newborn that has a temp between 97.9, or their normal temp should be 97.7 to 99.7. Here we like to see 98. If we're below 98, we bundle them up, do skin to skin. Okay. But if we do get below that 97.7, then we're going to do another intervention. Okay. Cold stress leads to the use of compensatory mechanisms or compensating. So increased respirations, metabolizing brown fat. So you're going to see, again, those increased respirations with cold stress. So when you're thinking, okay, you know, baby doesn't have a low blood sugar because you've assessed that, but now we still have these rapid respirations. What's our next thing? Hypothermia. Okay, cold stress. Preterm and SGA newborns are at risk for cold stress. They already have decreased adipose tissue, brown fat stores, and glycogen available for metabolism. The newborn is unable to respond to cold stress if it has hypoxia, intracranial hypertension, hypoglycemia. If you have these, you're going to consider the temp should be monitored more regularly. Okay, so if you already have these other 3 things going on, we need to monitor that temp because they're going to be ones that are going to easily drop their temp. So a newborn with hypoglycemia is anything less than 40 milligrams per deciliter. We may have transitional glucose level in the 30s. And if it's in the 30s, a lot of times we're still going to promote feeding as long as the respiratory rate is normal. If we have values in the 20 to 25 milligrams and it doesn't improve spontaneous or with feedings, then we're going to treat with the IV fluids of D10 to raise that glucose. You're going to see this most commonly in insulin-dependent diabetes mellitus, SGA babies, twins, preeclampsia, boys, preterm and macrosomia. Symptoms, we're going to see jitteriness, lethargy, poor feeding, poor suck, exaggerated Moro reflex. What's the Moro reflex? Startle. They're going to be really startled, okay? Jerkiness, jitteriness, eye rolling, high-pitched cries, cyanosis, apnea, hypotonia, tremors. But your biggest things that you're going to see is that jitteriness and a lot of times that exaggerated Moro. Those are going to be your two most common signs. And rapid respirations. So early feedings will help prevent hypoglycemia. We do not use glucose water anymore. Okay, we used to. But what happens? We raise that blood sugar and then all of a sudden we don't have that extra protein and stuff behind it to help maintain it. What happens? We're back down. Okay. We go from high to low quick. That's why we don't use glucose water anymore. We want to use like breast milk or formula. Okay. Because then we have that protein behind it to help stabilize. We're going to identify newborns at risk and we're going to monitor. So we're going to check blood sugar initially. So if we have a baby that mom's diabetic, we're going to know we're going to check a blood sugar. Okay. We have a baby that comes out and we know mom's supposed to be 39 weeks, but the baby looks like he's a toddler. I'm probably going to check a blood sugar without weighing him because he looks like a toddler. Or if I have a 39-weeker that comes out and looks like it's about 4 pounds, I'm going to check a blood sugar, even without weighing it, because I can kind of assess just by the look of newborn if it's going to be within that range. Okay. We're going to always check either before feeding or if they're symptomatic, but then like it depends on your policy. Here we just check Q hour times 4. Okay, it doesn't matter if it's before or after feeding. Okay. Monitor every 2 to 4 hours when stable or per the hospital protocol. So we are going to use a heel stick on our babies. Okay, and in your book, it shows you on page 625 how to properly select the heel stick because we aren't going to do like the base of the heel. We're going to use the outer side edges, not the back here. Okay, you're going to use those outer side edges of the heel. Okay. If you're unable to maintain the temp, check your glucose. Hypoglycemia, hypothermia go hand in hand almost all the time. Okay.
Why outer edge instead of like the
One, because it has better blood flow and less sensory nerves than the base of the heel. So you want to do the outer edges. And I know not every nurse does, but that's what you're supposed to do. Okay. And you also don't just squeeze it, you milk the foot. Because if you just squeeze, you're going to cause bruising. But if you kind of milk down like you would with a dairy cow udder, then you're going to help push that blood out and you're not going to cause direct pressure. And then you're going to release, let blood flow back in, and then milk down again. And you never squeeze like directly at the side. You have to milk because you're never going to get enough blood with just squeezing right at the side. And you're going to cause more bruising than anything to baby. Newborn with jaundice. Icterus neonatorum. Okay. This is a baby that has jaundice. They're going to have yellow skin, yellow sclera with our sclera, the whites of our eyes. So it develops from yellow pigmented bilirubin in the lipid fat containing tissues. So we're going to screen them prior to leaving the hospital, usually about 24 hours. So some causes on these babies. So we have RH incompatibility, or ABO incompatibility. So mom is O positive and baby's A or B positive. They're at higher risk. Okay, so if baby's A, B, AB, and mom's O, then they're at higher risk for that ABO incompatibility. These babies will also have a positive antibody screen in their cord blood. And if it's positive, we know they're at bigger risk. Medications exposed in utero, hemolysis, preterm newborn, so they have that lack of albumin for Billy to bind to. Hypo or hyperglycemia. This can result in neurotoxicity and encephalopathy if it's untreated. So idiopathic jaundice diagnosis is that baby has jaundice within the first 24 hours, then it's idiopathic. That means it's prior to when it normally would be, okay? So nursing care and treatment, we're gonna identify those babies at risk. So if we get that antibody screen back and it's positive, we know that baby's at bigger risk for having jaundice. Identify signs and symptoms of jaundice and rise in Billy levels. So we're gonna do here, we don't do a blood serum. We actually use our little Billy checker, it's a light. And we do it on the forehead, but you also can do it on the sternum. Okay, and it assesses the amount of bilirubin in this tissue itself. We want to encourage frequent feedings. But usually if our photo bilirubin is high, like our little light bilirubin is high, then we're going to do a serum bilirubin to check it to make sure it's accurate. So when a baby's jaundice, we're going to encourage frequent feeding to stimulate the bowels. We want them to poop because helping them poop is going to pull that bilirubin out of their body. Okay. Phototherapy may also be needed. That's where we put them under those blue lights and they get the suntan. Or sometimes it may be bad enough that they have to have a blood transfusion to then bring down that bilirubin level. Okay. It's called an exchange transfusion. So for phototherapy, we are going to expose the newborn to high intensity lights. So we're going to use bank lights, a fiber optic blanket. At our hospital, we also have a little mattress that they go on that the lights are coming up from. So we do that and the bank lights over baby. So we're going to expose the baby to fluorescent lights, LEDs, or blue lights. It helps decrease the bilirubin levels in the skin by helping biliary excretion or bilirubin and decreases serum bilirubin by changing bilirubin from non-water soluble form to water soluble form. And then it can be excreted in the urine and the poop.
And they do those Billy blankets at home.
Some places do. Yeah, when I worked in Arkansas, we had a home health. We had home health that if it was like high but kind of not super high, kind of like just that high right above normal, we would do the Billy blankets at home. But if they needed, if they were super high, they would come in and we would do it in the hospital. Years ago, we also, every baby that had hyperbilirubinemia got an IV because therefore you were trying to flush out the Billy that way. But now that's not standard of care anymore. We only do a IV if it's significantly elevated and baby's not feeding well. Okay.
Amanda, do you know how they figured out that phototherapy works or that light works?
How?
It's because it was during tuberculosis and they had like these little cages that they let the babies go out to help like prevent tuberculosis or help treat it. And they figured out that it helps with jaundice too.
That's pretty cool.
It didn't help with tuberculosis.
No.
It helped the jaundice.
And we do have moms that's like say they are elevated but not over the super high number. Then we will tell them to sun the baby. So we'll tell them to put the baby like in the sun, like sunlight coming through a window. Put them in their diaper inside the house, sunlight coming through the window, and that will just for about 20 minutes every hour, and that will help also break down those UV rays will help break down the bilirubin. The only thing we do need to be careful of is we need to monitor for dehydration and hyperthermia, okay? Because these babies are gonna be in a little, almost oven being lighted up. But we also have to watch for hypothermia because if it's the mom's keeping the room cool, and like here we use a Billy Light and we have blankets that we put around it and it kind of helps keep the heat in, but some places don't have those. Our bank lights that we had in Guyman just were over the bed, and so we didn't have anything to cover and keep some of that heat in. So they sometimes would get cold. So we're going to assess the temperature every hour on these babies to 2 hours, depending on your policy. We're also going to protect the baby's eyes against those UV rays. So they're going to have these little things that go around their head, okay? And we also have to assess their eyes frequently, okay? Because they're going to have these little foam covers over their eyes, and they may be trying to open and close, and you'll notice they'll kind of get some redness, and we want to make sure that it's not causing too much irritation. Newborns with infection, so sepsis neonatorum. Do you know what neonatorum means? Like in the baby. Okay. So neonatal sepsis, it's caused by organisms that do not typically use significant disease in other children, so or cause significant disease in other children. Infection in the newborn spreads rapidly through the bloodstream regardless of the cause. Remember, their bloodstream is very minimal, okay? So therefore they get septic very quickly. Your biggest causing agents are GBS and E. coli. Other things could be like a nosocomial infection, so an infection they acquire at the hospital, so it could be MRSA or Candida. These are common in hospital-acquired infections. So the immune system lacks the antibodies to help fight off these disorders or infections. So infection can also be caused by exposure to infections during the delivery or in utero, like STIs or the GBS. So again, we're going to assess the behavioral changes. Are they have lethargy? Are they irritable? Are they hypotonic, where they don't have good muscle tone? Do they have temperature instability, feeding intolerance, poor suck, vomiting, diarrhea, tachycardia, apnea? We may need to do blood culture, spinal culture, do urine and skin cultures if needed. Antibiotic and antiviral therapy may be needed, so we may have to do a cyclovir, ampicillin, Ceftin, Gent, Zinc, and on the Gent and Zinc, we're definitely going to monitor our peaks and troughs. NCLEX question. Okay. A 7-pound, 14-ounce infant was born 2 hours ago to an insulin-dependent diabetic mother. The infant's blood sugar is 47. What is the priority nursing action? Recheck the blood sugar in 6 hours. Begin an IV of 10% dextrose. Feed the baby 1 ounce of formula, or document the findings in the chart. We're documenting the findings, right? Because it's normal, right? 47 is good.
Over 40, right?
Over 40. Okay. A neonate needs to be gavage fed. What is the nurse's action prior to feeding? A, inject 10 to 15 cc's of air, listening with a stethoscope over the epigastrium for a sudden rush of air movement into the stomach. B, aspirate stomach contents with a syringe and note amount, color, and consistency. C, place the end of the gavage tube in water, in a glass of water, and watch for air bubbles. D, obtain X-ray verification of correct placement of the tube. Okay, why wouldn't it be A? Too much. Remember, little tiny tummies. Okay, so 0.5 to 1 ml. Okay. Who else said a different letter? It is B. We're going to aspirate the stomach contents with a syringe. We're going to note the amount, color, and consistency, and then what are we going to do with it? Put it back. Chest X-ray?
Yeah, for the placement like you do in adults.
Not for the gavage. No. Initially you will, but you won't for every feeding. So only whenever it's the initial, and even then, not always. We don't always on a baby, as long as you can hear the air, little bloop, bloop, or the whoosh, whatever, which one you hear, okay? A nurse in a neonatal intensive care unit receives a telephone call to prepare for an admission of a 43-week gestation newborn with an APGAR score of 1 and 4. In planning care for the admission of the newborn, what is the nurse's highest priority? A, turn on the apnea and cardiorespiratory monitors. B, connect the resuscitation bag to oxygen outlet. C, set up the IV line with 5% dextrose in water. Or D, set the warmer control temp at 97.6 degrees Fahrenheit. Okay, why B? APGAR scores are low, right? So always we go by our A, B, C's, right? Usually almost 100% of the time, not always. If it's related to an airway, especially when you know a baby or the person or baby, whoever already is in distress, that's going to be your most correct answer. Okay. Which neonate is at highest risk for developing cold stress? A neonate that was delivered at 42 weeks, 6 days. A neonate diagnosed with Down syndrome. A neonate that is AGA. A neonate that has a blood sugar of 50. Why A? Post date, so it could be what? Skinny, right? Because it's probably lost some weight, that brown fat has disappeared because it's had to use it for energy. And so now we've got this post date babies with no excess fat. Okay?
That would be with preterm.
Preterm as well, yes. Okay. So the last group has their simulation today at 1. So if you're in that group, I'll see you at 1. Tomorrow, we will test at 9. Okay, so be here at 9 o'clock. We will take our test. Your case study is due by 8:30 in the morning. It will close at 8:30. If you do not have it submitted by 8:30, I will not accept it. And you will get 0 points for your case study. Okay. I will, so when you get it turned in, I'm not like putting in the point grade on it because I need to add it to your other grade. So I'm doing excuse, but I am putting in the comments the points that you're getting. Okay. So once you submit it, if you get submitted before in the morning, I will grade it today because that way I don't have to grade everybody's during the test. And I will give you what points I'm going to give you for that. I will make comments. I'll highlight, like if something is not what I feel like is the correct answer, I'll highlight and give you comments of what it should be. Okay. So if you look at it on your phone, you won't be able to see the comments. You'll have to look at it on your computer. Okay. Okay. Any questions? Okay.